Good evening, everyone. How are you all? Welcome to First Aid AMC MCQ free 2-week sessions. So tonight we are going to do cardiology question solve, right? So we have finished cardiology theory by so far, and you had 2 classes for cardiology theory with me. And I hope that you also have got a few of the question solvation classes with us, right? One class was with Dr. Rabia, and also we had few classes on question solvation. Tonight we'll focus on how we can use our theory knowledge on solving some questions. So in every time when we finish a topic, like let's say cardiology, respiratory system, pediatrics, we will have this kind of subjective question solve class after having your theory finished. This will give you an idea that how questions can come in the exam and how to prepare for that. Okay, and also with Dr. Rabia, you got to understand some of the random question solvation, like which can come from anywhere. Just like in your exam, the questions can appear from every part of your syllabus. So Dr. Rabia will focus on that, but me as part of it, we will mainly focus on solving the subjective questions. Okay, so in that way, you will have idea for both. So let's start our tonight's session, and we'll see that how you have gathered knowledge on cardiology. Now tonight we have added some questions from palpitation and ECG as well, but as we know that we haven't done ECG yet. So because this is only the cardiology question solvation class, so just we will discuss about those questions in detail. But if you don't understand the topic, that's totally fine. Okay. So let's start. So this is your first question. You have got a 17-year-old male who was running a race and suddenly collapses on the floor. Luckily, someone was there and performed CPR as patient did not have a palpable pulse and resuscitated him. Upon arrival to the ED, it is revealed that his father died at the age of 28, so early cardiac death. He is now alert, asymptomatic, ECG was non-eventful, and he is anxious to go home. What would you do next? So they're asking you that a patient who is just like a young adult, like a teenage patient, like 17-year-old male, had a history of a collapse, and then patient also needed to have CPR. There is a very important clue here that early cardiac death in the family. You have done ECG, that was normal. What will you do next? Send him home and arrange an outpatient consult with a cardiologist. Send him home, admit and refer for cardiologist consult, arrange an outpatient echo, or you do an stress echocardiogram right now. So what will you do next? Next means always the initial, right? So what is your next step for this patient? Yes, very good. C, right? Because obviously you are going to do a stress echocardiogram here, but who is going to arrange that? Not you, not as a ED team. The cardiologist will arrange that echocardiogram if he thinks it is needed. So the first thing that you do is to admit under cardiology. So that's your next step. And after that, they can arrange further investigation and management. All right. What's your most likely diagnosis in this case? Like a history of a syncope in a patient who has a sudden cardiac death history in the family. Yes, likely chance is HOCM. Good, very good. Moving on to the next topic. A young athlete presents with history of sudden syncope and dyspnea. ECG shows left ventricular hypertrophy. Patient's father had sudden death at very young age. What is your initial treatment for this patient? So again, a young athlete, sudden syncope, dyspnea, ECG showing left ventricular hypertrophy. There is a family history as well. Most likely diagnosis is HOCM, right? So what will be your initial treatment for this patient? Verapamil, septal myomectomy, defibrillator, low molecular weight heparin, or adenosine. If you remember our discussion on HOCM, the treatment is either you go for a beta blocker or calcium channel blocker. We try to avoid digoxin, diuretics, vasodilators, right? So in here, we haven't got any beta blocker. We have got calcium channel blocker, which is verapamil. So that will be our answer. Okay, very good. Moving on to the next. So you will see that just one question, it can come in so many ways in the exam. So you have to have a very good idea and a basic knowledge on a particular topic to get a correct answer in the exam. Okay, so a young girl, 15-year-old, collapsed at exercise. Her father had HOCM. After ECG and echo, you found no abnormality. What is your next step? So a young girl, 15-year, collapsed at exercise. Her father had HOCM. After ECG and echo, you found no abnormality. What will be your next step? Now, still it is HOCM is your most likely diagnosis. So what you are going to do, you have done a ECG and a echo. There is no abnormality. Alter, stress echo, repeat echo now, or repeat echo after 3 years. If you remember what we have discussed in the class, if you get a patient who you suspect to have HOCM, usually the best idea, if you have done a resting ECG and echo and that's normal, the next best step is to do a stress echocardiogram, right? So you guys remembered everything that we have discussed in that class, so that's really nice. Same question. Now, a 9-year-old male was playing football and suddenly collapsed on the floor. On arrival to the ED, it is revealed that his father died at age 28, now alert asymptomatic. What would you do next? Alter, stress echo, repeat echo, ECG, or echocardiogram? Now, this is the tricky one. So what you want to do next in a patient like this? Very good, guys. So you actually remembered what I said about it. If you even have a look here, they always have done ECG first, right? So all the questions, if you go through, first they have done ECG. So initial is always ECG, and then you can do an echocardiogram. So for this case also, we will do an ECG first. So that was all about HOCM. And as you can see, 5 questions we have done, all from the same topic, asking different kind of questions. That's actually how in the exam you will come across. Like maybe you have done a question with us or maybe through Amadex or somewhere, but the question pattern will be different in the exam. So that's why we say that it's not about memorizing the answer of a particular question. It's about understanding the topic clearly and knowing a step-by-step approach. Okay. A 16-year-old male who presents with a ejection systolic murmur in the second left intercostal space. Which of the following is likely to be the diagnosis? So everyone has ASD, atrial septal defect. We haven't done the pediatric cardiovascular system because that's a part of pediatrics class. But we will discuss that. So you have got ASD in every option, but ASD with aortic stenosis, ASD with mitral stenosis, ASD with pulmonary hypertension, or ASD with aortic regurgitation. Now we will discuss this equation first so that you understand what we are talking. So let's start one by one with ASD and VSD. First of all, atrial septal defect. So you remember that if this is your heart, That's your right atrium and that's your left atrium, right? And if this is intra-atrial septum, if there is any defect in this septum, blood can easily flow through this, and that can cause a murmur. Okay, so a lot of things are here. Patient with ASD can be asymptomatic. Sometimes if it is symptomatic, they will present to you with a heart failure symptoms, like a child. And the most common symptom will be exercise intolerance or shortness of breath on exercise or exertion. When it becomes significant lesion, sometimes you can get a low-pitched diastolic rumble. Okay, so the type of murmur that you look for in case of ASD patient is, first you get a systolic ejection murmur along the left mid to upper sternal border. So usually you get it in the left upper sternal border, and that's the ejection systolic murmur. Our patient has got a ejection systolic murmur, so that's ASD. Sometimes ASD patient can have a double murmur, which is a diastolic rumble. That's also one of the exam question. So remember that ASD can give you double murmur. Now, when a patient develops ASD, what happens? That's the main particular part. So let's see. Initially, your left side of the heart has more blood flow and more blood pressure. So always fluid will go from the high pressure area to the low pressure area, right? So initially what will happen, there will be a left to right shunt. So blood will flow like this. Eventually, when more and more blood coming to the right side, at one point, right-sided blood pressure will be higher than left side. Okay, and then blood will start to go to the reverse side, and that is what we call as reverse shunt. Okay, and this reverse shunting from right to left side has also a name. That's called Eisenmenger syndrome. Okay, now when blood will start to go to the right side, what will happen? Sorry, when blood will go from right to the left side, more and more blood will accumulate in the left side. At one point, left side will be totally full. Then it will cause a backflow of blood to the pulmonary vein, followed by the lung will get edematous. When lung gets edematous, then pulmonary artery eventually will become full with lots of blood, right? Just like how we discussed initially. So it's all about backflow. From left atrium, backflow to the pulmonary vein, then to the lung, then to the pulmonary artery. So what will happen to the pulmonary artery? When there is a more and more blood flows to the pulmonary artery, there will be pulmonary hypertension. So ASD can easily get complicated with a pulmonary hypertension. And that's actually your answer in this case. So ASD with pulmonary hypertension is most likely the reason of giving you this ejection systolic murmur in the second left intercostal space. Okay, because all other murmur, aortic stenosis, ASD, these are not interconnected. Like these are very different things. ASD, mitral stenosis, ASD, aortic regurgitation, all are double diagnosis, but this is the only one which is a complication of ASD. So ASD can get complicated with pulmonary hypertension. Pulmonary hypertension itself will not give you any murmur, but sometimes if there is a lot of blood flowing through the pulmonary valve, then it can give you some murmur, but that's not the case in here. Okay. You can also get the ASD murmur from med bullets. So you can go through this link as well. Now, very important along with the ASD is VSD. The most common murmur or most common heart defect in a child is VSD. But the VSD usually gives you a different murmur. The murmur of VSD is called pansystolic murmur, and it's actually a little bit lower sternal age. So upper sternal age on the left side, and ejection systolic murmur is ASD, and VSD is a hollow systolic or pansystolic murmur, but it's on the right side, lower sternal age. Okay. Now, Dr. Davy, that's right. Diastolic rumble is also in MS. But the important thing, in a child, we will not think about MS at the first time. We would think about ASD, VSD as our first diagnosis of a murmur. All right. But in an adult, we will think about MS, or if it's a rheumatic heart disease patient, we will think about MS-MR at first. So it's case by case. But yes, it can confuse you. And the only way to definitively know is doing an echocardiogram. All good? Any questions so far, guys? Just give me 1 second. I think I'll just need to cross the right answers from some of the questions. Okay. Moving on. A young adult guy, while playing cricket, suddenly had a syncopal attack without any convulsive feature. Soon he spontaneously recovered and started fielding, continue playing rest of the game. What is the cause? So that's actually an important question of syncope. Now, if you know about syncope, then you will understand that normally we divide syncope in a lot of different subtypes. But syncope means sudden loss of consciousness. And there are mainly importance are cardiogenic syncope, so cardiac causes. Then we have neurogenic causes and some reflex causes. Okay. One of the reflex one is your vasovagal syncope. Okay. And then there's cough syncope. Then you have micturition syncope. A lot of syncope causes are there. The important thing to remember when you are getting a questions from syncopal attack is that understand the way of having the syncopal attack. If a patient suddenly lost consciousness without any prodromal feature, and then suddenly they come back to life, or spontaneously they recover without any drowsiness or confusion after that, it's likely to be a cardiogenic syncope. So cardiogenic syncope happens suddenly and they recover suddenly without any other symptoms. Just like this patient who was playing cricket and suddenly had a syncopal attack, and then soon he spontaneously recovered without any confusion afterwards. That rules out the possibility of epilepsy, because epileptic patient will have a convulsion, obviously, and also after regaining consciousness, they will be confused for at least 30 minutes, which we call as post-ictal confusion, which is not here, so it's unlikely. Then postural hypotension. Postural hypotension is common in elderly patients, especially who are on multiple medications, and most of the time, a new medication like a antihypertensive has been added, like a diuretics has been added, or maybe a ACE inhibitor has been added, or recently you have increased the dose of a blood pressure medication. So because of volume depletion, sometimes When they change their position from sitting to a standing position, they can feel dizzy or sometimes even lose consciousness. That is what we call as postural hypotension. So postural hypotension patient will say that, doctor, when I'm getting up in the morning, I feel dizzy and sometimes I'm about to lose consciousness. So when they get up from the bed in the morning, they change their position, right? From lying or sitting to standing. When they stand, their blood pressure drops and they feel very dizzy. So that's postural hypertension, common in elderly patient, which is unlikely in here. Can be neurogenic syncope, but neurogenic syncope takes a little bit more time to become fully conscious. That means it can happen suddenly, but it does not regain consciousness spontaneously without any confusion. So neurogenic syncope patient might have a little bit of confusion, but not like epilepsy. Whereas cardiac syncope just totally spontaneous. Suddenly happens, suddenly they recovers. Vasovagal syncope, the classic picture is maybe the patient was running under a hot sunny weather and was sweating a lot, or maybe standing for a prolonged time, like those who are in armed force. And suddenly what happens that their vagus nerve gets stimulated, and vagus nerve causes peripheral vasodilation. Because of peripheral vasodilation, blood pools at the lower extremities. So if your lower extremity is having all the blood, your heart is not getting enough blood supply. If your heart is not having blood supply, your heart is not pumping enough blood to your body, your brain is not getting blood, and you are getting this dizziness or syncopal attack. So that's what we call as vasovagal syncope. But vasovagal syncope classic picture is that before falling, they will know that they are falling. That means they have a prodromal symptom. And prodromal symptoms are, they might be feeling a little bit lightheaded. They might have feeling of sweaty, then shaking, or maybe blurring of vision. So some prodromal symptoms will be there before they fall. So that's vasovagal syncope. Okay. So I hope that you understand it and you will never forget about any of this syncope. So our patient having a cardiac syncope. All clear about syncopal attack, guys? Good. A 45-year-old male presented to the emergency department with left-sided chest pain radiating to the left arm and jaw. There is no ECG changes, troponin negative 4 hours since the onset of chest pain. He has been on sildenafil for erectile dysfunction, metformin for type 2 diabetes, ramipril for hypertension. What would be the most appropriate next treatment? So you have got a patient who is having left-sided chest pain, 45-year-old, no ECG change, no troponin rise. He is on some medication. So what will you do next? Nitrate, heparin, morphine, beta blocker, paracetamol. So I'm getting mixed answers, C, B, A. All right, the first thing is that we don't know what kind of problem this patient has got. All we know that this patient has got a cardiac looking chest pain, right? But it's still the ECG and troponin is still negative. So it's likely to be an unstable angina, right? Because troponin 4 hours, it should be elevated by now. So there is a chance it could be unstable angina, or it might be MI. If we do a repeat ECG and troponin and later on it becomes elevated, then we can say it's a MI. But right now it is still unstable angina. So what we can do so far? First of all, beta blocker, and first of all, rule out paracetamol because it is unlikely to be your answer. Next is beta blocker. Beta blocker is not your first line treatment. Then nitrate. Can we give nitrate to this patient? No, because this patient is on Viagra, sildenafil. You should not give sildenafil and nitrate at the same time. Contraindicated. Okay. Now you have got B and C. Heparin would be a good choice if there was any changes, like either troponin is elevated. If you know that this is a non-ST elevated MI, then heparin would be your best choice. In this case, the best would be giving a morphine because still patient has got chest pain. Okay, so the idea is that choosing heparin is usually needed if a patient has got a non-ST elevated MI. Other than that, heparin is not your initial choice. Not every patient who is having a chest pain will end up getting a heparin. Usually MI patient gets it. All right. So out of all of these options, it will be a best idea. First, treat the chest pain. If there was an option of giving aspirin, that would be the best choice here, but it's not in the option. All good? So that's your answer. Heparin, keep it for non-ST elevated AMI. Next, a 72-year-old male presented with severe chest pain radiating to his back. On cardiac exam, you notice a diastolic murmur. Chest X-ray shows widening of the mediastinum. You have got a ECG. What is the most appropriate management? So you have got a patient, 72-year-old, severe chest pain radiating to the back, diastolic murmur, wide mediastinum. Now you have got this ECG. Let's have a look to the ECG a little bit. In myocardial infarction, you look for ST elevation, right? Now V1 to V6 is your chest lead. So let's have a look to the chest lead first. So in the chest lead, you can see that there is ST depression here. For those of you who don't understand ECG that much, we will have our ECG class in the course, then you will understand much better. We will not go that much detail today. So in V1, you have got ST depression, V2 ST depression, V3 a little bit, V4, V5, V6, you have got little bit elevation. Lead 1 and AVL, AVL has got ST depression. Lead 2, 3 AVF. Lead 2, 3 AVF has got ST elevation. Now this patient has got likely to be an infralateral MI. It's not very common to get like V5, V6 elevation with inferior leads, very uncommon, but it is in the ECG, but you have got your reciprocal ST depression in some of the chest lead, okay? So it's likely that it is an inferior MI. Whatever it is a MI patient. Now, my question is, does MI patient comes with widening of the mediastinum? Does just a MI patient have diastolic murmur? No, there is something else also going on. What's that? This patient most likely has got an aortic dissection. An aortic dissection has got complicated with a myocardial infarction. Sometimes if aortic dissection happens very close to the coronary artery, it can get complicated with a myocardial infarction as well. So this patient has got both. Which one is more urgent? Actually, dissection is even more urgent than MI because this patient can just die. Now, when you have got two things at the same time, dissection with MI, what will be your management? So they're asking for most appropriate or definitive management. So give altiplase, which is a clot dissolving agent. Give aspirin and intravenous morphine. Morphine, beta blocker, arrange for transesophageal echo, refer the patient to cardiology clinic, consider urgent MRI of the cervical and thoracic spine. That's unlikely. What will you do next? The best option in this case is that this patient having chest pain, so give morphine. This patient having a possible aortic dissection, so control the blood pressure, give a beta blocker, and arrange for a transesophageal echocardiogram. In the emergency department, you can do it. You don't need to refer the patient to cardiology clinic for that. Okay, so you will have to manage this patient. First, you do these three things. Once you know that this patient has got a aortic dissection, then cardiology team will be involved. But this patient has got a MI. Can you just do a streptokinase or retiplase or alteplase in that patient? No, that's a contraindication. When a patient has got aortic dissection, this clot dissolving agent or thrombolytic agent becomes contraindicated. You can't do that because it will make it worse. Okay, so not much of an option in this case, but you will have to manage this patient as soon as possible. But this is the best option out of all of this. And you remember we have discussed about aortic dissection. This is the widening of the mediastinum you can get. And there are two types of aortic dissection, right? If we divide it like this, this is your left subclavian artery. Proximal to it is a Stamford A dissection, which needs surgical management. And distal to left subclavian artery is your type B, which sometimes initially you can manage with medical management of controlling the blood pressure first. All good. Moving on to the next. An elderly man with multiple falls during the day, especially in the morning after waking up. So even by looking at this, you know what this case might be. ECG shows left ventricular hypertrophy and multiple ventricular ectopic. Orthostatic hypotension also noted. How will you investigate this patient further? So multiple fall in an elderly patient, and you have already got postural hypotension. So you want to do a repeat measurement of BP in supine and prone position, 24-hour Holter or serum electrolyte. I can add another option like, let's say, you want to do a echocardiogram, or you want to do a ambulatory blood pressure monitoring. So among these 5 options, what do you think you want to do first? Multiple fall, elderly patient, ECG have found some of the arrhythmic problem, orthostatic hypotension also noted. Now you want to do A. What is A? Repeat measurement of BP in supine and prone position. What is supine and prone, guys? So you want to check the blood pressure in lying position. What will it give it to you? Nothing. It's just a trap. Because if you actually want to confirm the postural hypotension, which is not a bad idea because you need repeated measurement for it, but you will have to do it on sitting and standing position. But it's supine and prone. So it's obviously will not give you anything. It's just a trap in your exam. So in this case, if there was an option of repeat measurement of blood pressure in sitting and standing position, yes, that will be your next choice, but not this one. For this one, let's say electrolyte will not give you too much information. Ambulatory blood pressure monitor, why we are going to do it? This patient, we already know that this patient has got a postural hypotension, not hypertension. So no need of doing a BP monitor. How about echocardiogram? Well, we can do it, but not our next option. Our next option would be a 24-hour Holter monitor. Why we do a Holter monitor? To find out arrhythmia. You already have got ventricular ectopic in this patient. Sometimes a patient can have some underlying more arrhythmic disorder. And if you just do a resting ECG, during that time, you might just get some ventricular ectopic. But maybe during other time, patient is going into a heart block, or maybe during other time, patient going into AFib. So if you don't do a 24-hour Holter monitor, you will not get that thing. So that's only time we do the Holter monitor if we want to know further about if there is any other arrhythmic disorder going on in this patient. Okay. So that will be your option in here. So that was your syncope case we have discussed already, like how to get the syncopal thing. Now for syncope, there is a chapter in your JAM. We will do the, I think we will do your syncopal case in neurology. So in neurology, when we will come to that in the course, we will discuss some funny terms, fainting and syncopal attack. So during that time, you will get to learn a lot about syncope. This case now, it's actually multiple diagnosis. So this patient having a fall in an elderly can be due to a lot of causes. So it's always a multifactorial thing. This patient fall can be due to a postural hypotension, can be also due to some underlying arrhythmic disorder, which we want to find out now. Next, a young patient has been getting multiple lightheadedness. So it's a young patient. The age and sex of a patient is very important. So always keep an eye on it. So young patient has been getting multiple lightheadedness and dizziness. His clinical features normal, ECG chest X-ray normal. Holter monitor shows some ventricular ectopic. Ventricular ectopic are very common arrhythmia. It's one of the most common finding. And it's just some abnormal beat, nothing else. What will you do next? Reassure the patient. You want to do a exercise tolerance test, dobutamine induced echocardiogram, or a plain echocardiogram. Now, there is a chapter in your JAM, which is palpitation chapter, which we have kept during our ECG class. You will find this one also there. So it's called premature or ectopic ventricular complex, PVC. These are usually asymptomatic in 90% cases. They occur in 20% people with normal heart also. Symptoms are usually noticed at rest in bed at night. Drugs that can cause this kind of premature beat is mainly digoxin and some sympathomimetics, like if you're taking salbutamol, adrenaline, those kind of things. Look for evidence of ISD, mitral valve prolapse, hydrotoxicosis, left ventricular failure. If symptomatic, but otherwise well, with a normal chest X-ray and an ECG, reassure the patient. So this is the line from where the question actually came. Symptomatic, otherwise well, normal chest X-ray, normal ECG, reassure the patient. Let's have a look. Young patient, symptomatic, clinical features normal, chest X-ray, ECG normal. What will you do next? Nothing, just reassure the patient. There is nothing wrong with getting a PVC in a young patient. Now, drug therapy. Never commence drug therapy without performing an echocardiogram, because if there is a structural deformity in a patient's heart and you start the patient with antiarrhythmic drug, it can cause a lot of trouble. So before starting any antiarrhythmic drugs, do an echocardiogram in this patient. For troublesome symptom, you can give them some beta blocker like atenolol or metoprolol. But that's usually even not needed, especially if it's the elderly patient who is getting fall because of this PVC, you can give them atenolol or metoprolol. All right. So for this patient, you don't need to do anything. It's a young patient, ECG chest X-ray normal, Holter only showed ventricular ectopics. It's fine. Just reassure. No, if you only need to do a echocardiogram if the patient needs a drug. So never commence drug therapy without performing an echocardiogram. This will help to guide the choice of agent. So only time you normally do that, young patient, not every young patient needs a echocardiogram. Okay, so only time you will need to do it if it's a troublesome symptom, then you can do it. If there is a structural deformity in this patient, you would get a murmur. Okay, so that's usually should prompt you to do a echocardiogram. Without any other clinical signs, no need to even send the patient for a echo. A patient on amlodipine and amiodarone, furosemide aspirin, having intermittent fall, ECG given looking like a hyperkalemia ECG. Now, this case is a very controversial question, and we don't have much of explanation because this is actually not very promising type of question to me as well. Because none of these options they have given, it's not very important to cause hyperkalemia. So we have got amlodipine furosemide. Now, furosemide is a diuretic which causes hypokalemia. Amlodipine amiodarone, aspirin amlodipine, aspirin furosemide. Same with the furosemide, it causes hypokalemia. So it's unlikely that this will cause hyperkalemia anyway. You have got two options, B and C. Now, we have tried our best to find out the answer of it, but not much of an explanation we could come out because none of this medication actually increases potassium in that extent. The only thing that sometimes can be like amiodarone itself can increase the potassium. Just that might be the only thing that I can say that it can be the answer for this particular question. Okay, so amlodipine calcium channel blocker, not much of potassium increasing effect, but sometimes amiodarone can do it. It's even like a rare side effect kind of thing. So if we just think about amiodarone causing hyperkalemia, we can keep this as our correct option. But as I say that this is a very controversial question, not much of the explanation is there. Time to time, you will come across such a question which will feel like a waste of time. So my suggestion is don't waste a lot of time on those questions because it's maybe just coming wrong from the other hand, or maybe it's just a mistake from someone. So don't bother too much with these kind of questions. Scenario about multiple drug, including ramipril, amlodipine, hydrochlorothiazide, celecoxib, asking about which combination making muscle weakness without tenderness. Now, this is a good question. You get a lot of questions from pharmacological side effect in the exam. So have a good idea about the side effect of common medication. All of these medication in here are very commonly prescribed. So ramipril is a ACE inhibitor, amlodipine calcium channel blocker, hydrochlorothiazide, thiazide diuretics, celecoxib is the NSAID. So which will cause muscle weakness without tenderness? Ramipril and hydrochlorothiazide, amiloride ramipril, and celecoxib hydrochlorothiazide. What do you think? Now come to the point. Hydrochlorothiazide is a thiazide diuretic which causes hypokalemia. Ramipril is the ACE inhibitor. It can cause hyperkalemia. Both of them should counteract each other and should not have any problem. Celecoxib is a NSAID which can increase potassium. Hydrochlorothiazide decrease potassium. Again, counteract each other. The only option is also remaining is B. So B is amiloride, which is a potassium sparing diuretic like spironolactone. So amiloride will increase the potassium. Ramipril will increase the potassium. And both of them can give you hyperkalemia. And if you know about hyper or hypokalemia symptom, both of them can give you muscle weakness. It does not give you any tenderness, but generalized muscle weakness is a feature of both hypo and hyperkalemia, right? So that's your answer. Okay. Moving on to the next topic. So ECG of an adult patient who presented with chest pain, cardiac engine, and first ECG normal. BP 120/70. After 8 hours of observation, his BP goes down to 89/50. And ECG showing supraventricular tachycardia, heart rate 150. What would you do? Now, again, we haven't discussed SVT in your class yet. So supraventricular tachycardia is one of the common cause of tachycardia, which comes in exam as well. So in supraventricular tachycardia, patient will come to you with palpitation. The management is important. They have already told you that what will be the finding in ECG. So we know it's a SVT. When you come to the management of SVT, the first thing that you know is that patient vitally stable or unstable. So first thing that you find out is the vital, because management depends on this. What is unstable SVT? Unstable SVT means if blood pressure less than 90/60, if a patient having altered mental status or confusion or coma, if a patient having severe chest pain with shortness of breath, these are unstable SVT. For a unstable SVT, there is a particular management which we will come later on. Stable SVT, initial management will be conservative. The conservative management is vagal stimulation. So there is a lot of way to do the vagal stimulation. You can do carotid sinus massage. You can do Valsalva maneuver. You can even just immerse your face in a cold water. Okay. So any of this vagal stimulation will be your first choice in a stable SVT. If that does not help, the next is medication. The commonly used medication is adenosine, as all of you are saying. And adenosine is the IV adenosine, which you can increase gradually. You can repeat adenosine if it is not controlling. If adenosine is ineffective, you can also try calcium channel blocker like verapamil. Second line option. Even after that, still patient is not having a controlled SVT, the last option would be DC cardioversion. DC cardioversion means giving a shock to revert back to the normal rhythm. So that's your last resort. But DC cardioversion is the first resort in unstable SVT. For unstable SVT, you can't try any of these things because you don't have that much time. Patient can get into like a cardiac arrest because of that. So for a unstable SVT, the first line management is DC cardioversion. The other name of DC cardioversion is synchronized cardioversion. Why it is synchronized cardioversion? Because in defibrillation, you can just give shock anytime. But in synchronized cardioversion, you give shock when you see R wave in your monitor. So whenever you see R wave in the monitor, you give the shock. That's called synchronized cardioversion. Whereas in defibrillation, you don't follow any rule, you just give it. Synchronized cardioversion is usually the type of shock you give in a patient with SVT and atrial fibrillation. Okay, so that will be your answer in this patient. Why? Because this patient's blood pressure is 89/50 now. So that's an unstable SVT. Okay, clear guys? Any question? If they ask you, is there any curative treatment for SVT? Yes, there is a curative treatment that's called radiofrequency ablation. Moving on to next, a patient on digoxin, bisoprolol, and thiazide. Long-term history of hypertension and congestive cardiac AF. Stopped taking medication for 3 weeks while on vacations. Now presents with edema up to his knees and a raised JVP of 4 cm, but with clear chest sound. Blood pressure 145/90, pulse irregular. What would you do as your initial management of this patient? Very tricky question for exam. This is a patient who is having AF complicated by congestive cardiac failure. That's the gist of it. A patient who has CCF, if they don't take medication for 3 weeks, obviously that will get worse, right? And you can see all the medications is related to heart failure as well. Some of them are heart failure medication, some of them are AF medication. Now, and in terms of symptom after 3 weeks of not taking the medication, patient having edema to the knees, raised JVP, which are feature of heart failure. But the important clue here is that this patient has got a clear chest sound. What does that mean? It means it's not a left ventricular failure or it's not a pulmonary edema. If a patient having pulmonary edema, that's the main step that you start the patient immediately with furosemide. Okay, that's usually the only time you would start a patient with furosemide, not a patient who is having leg edema or having a raised JVP. Okay, so the best approach in this case, because this, if you can control the heart failure and AF like before, most likely this patient would not need furosemide at all. So you start all the medication as the patient was taking previously. So recommencing all medication will be your initial management for this patient. The same question can come a little bit different way. That means sometimes they can say that everything is same, but they say that patient having a bibasilar crepitation. If a patient having bibasilar crepitation, that means having a pulmonary edema, and patient also having a shortness of breath. So pulmonary edema, at that time, your initial management would be commence furosemide. So furosemide will be your initial management. Then you can start all other medication. All right, any question with this one? So the basic thing that you should remember that what were the medications patient were on previously. Now, obviously, we could start a lot of other medication in this patient, right? Like spironolactone is a very good medication to start with, but this patient was not on those medications before. The question is about what medication patient was on, right? So patient was on bisoprolol, thiazides, and digoxin, and that was controlling the heart failure. So if that can control the heart failure, we don't need to give anything else as an extra at the moment. The decompensated heart failure will be, especially if a patient develops pulmonary edema, that's the time we usually will use the term as decompensated heart failure. Raised GPP 4 centimeter, it's still is not that much high. If it was really decompensated, patient will not be able to take breath. So you will find out that patient is having shortness of breath, patient having a bibasilar crepitation showing pulmonary edema. That's usually the decompensated heart failure where we would not start the patient with bisoprolol. We would just withhold bisoprolol and we would just try the others. Okay, the main thing in this kind of question is that what was the medication patient was on before? They are not asking you that what medication you want to start now, right? Because this patient was a known case of heart failure and AF, and that patient was already on these medications before, which was controlling everything. So the main initial, like let's say this patient comes to you what would you do? You would recommence all the medication. Sometimes even with recommencement of all the medication, these things will not get any further. You don't need to do anything else. Obviously, if it still get worse, you have the option of adding a spironolactone. If it becomes pulmonary edema, you can start furosemide. It's all in your hand. But this patient still is not decompensated. Okay. Moving on to the next question. Given ECG, so you have got a ECG which is showing a M spike QRS complex in all leads and long lead too. Now, M spike QRS complex can mean a lot of things. It can be a left bundle branch block. It can be right bundle branch block. We don't know. Also on long lead 2, all QRS are M spike and irregular. So we understand that it might be a ECG which has AF with some bundle branch block, right? Without looking at the ECG, it's very hard to say. So heart rate is 150. Patient having hypertension and blood pressure 150/90. Patient taking atorvastatin, which is a cholesterol lowering medication. There is no chest pain. Asking for what is your next management. So basically what we can understand that it's an AF patient who is having hypertension and tachycardia, and they're asking for the next management. So it's just a management of atrial fibrillation. Atrial fibrillation management is a long thing which we will discuss in detail in our ECG class. But as a basic approach, remember that if an AF patient is a stable AF patient, you can start with either a rate control medication or rhythm control medication. The rate control medication will be either beta blocker or calcium channel blocker. So you'll just need to find that out. You have metoprolol, which is a beta blocker. You have verapamil, which is a calcium channel blocker. Both of them can be your option. But in such case, you will need to find out what would you usually use in a patient like this. The first line rate controller is always beta blocker unless it is contraindicated. So in this case, metoprolol will be your first option. Okay. And there are a lot of other things like we use apixaban warfarin in AF patient as part of a preventer of a stroke, but we will come to that point later on. A middle-aged man with a known hypertension started feeling dizziness and he feels his heart is racing. So middle-aged man, hypertensive, dizzy and heart racing, which means palpitation. It occurred after running. There was also travel history few days ago. Patient is on blood pressure medication and well controlled. No mention of diabetes. Blood pressure is normal. No postural change. Asking what is the most appropriate next investigation in this patient. So a middle-aged patient who is hypertensive but blood pressure well controlled on this medication, feeling dizzy and palpitation after running with a travel history few days ago. What would you think in this patient? So what we have got is it's a middle-aged patient with dizziness and palpitation. No chest pain. If this patient having chest pain, we would mainly think about possibility of a ischemic heart disease. Then we would do a ECG and a troponin. But there is no chest pain in this case and no diabetes. So it's unlikely to be a silent MI. So what else it can be? Likely that patient had a travel history. That's very important clue to deep vein thrombosis. And deep vein thrombosis can get complicated with a pulmonary embolism. And pulmonary embolism main feature is palpitation. Sometimes because the lung is not getting enough blood, then the patient can have hypoxemia and feel dizzy. So not an uncommon feature. If you suspect pulmonary embolism, what is your most appropriate investigation? CTPA is your most appropriate investigation for those cases. Okay. Even if they ask you initial investigation, that will be your CTPA. In pulmonary embolism, our initial, next, best, everything is CTPA. There is a lot of discussion about pulmonary embolism, which we will do in our respiratory system. Okay, but this case is most likely a pulmonary embolism based on the travel history and symptom. All right, now I think like let's take a 10-minute break now, and then we will do other cases. Any questions so far, guys? You guys are understanding? And you can have an idea that how question can come in a lot of ways in the exam. This is the thing, like for in the exam, you might not get every information. There will be a very small information in the exam. That's how the MCQ exam usually comes. It's not too much information. Like the rule is that a patient will never come to you with everything. Every patient has different kind of clinical feature that they come to you. So a MI patient or a pulmonary embolism patient can have a lot of symptoms, but they might not come to you with everything, right? So you just need to get the best answer out of information that was given in your stem. That's the tricky part. All right, so let's take a 10-minute break and then we'll do some other questions. Thank you. All right, everyone, let's start again. So that's your case. Now, you have got a patient who is 60-year-old male. 10 years history of hypertension, feeling dizzy and lightheadedness from this morning when he was doing exercise. Smoking 20 cigarettes a day, drinking 2 to 3 glasses of wine. Blood pressure 138/80, sitting. So that was the sitting one, and lying is 120/75. Currently on irbesartan, thiazide diuretics, and aspirin. Symptoms lasted for about 2 hours. ECG was given showing SVT, heart rate around 150 per minute. What is the cause of his presentation? Dehydration, ischemic heart disease, hypertension, alcoholic cardiomyopathy. You will have to think it as a whole. So let's say that you have got an ECG of SVT in a patient, right? But think the all other history that is given. Patient is a 60-year-old male, so that's one of the risk factor. Second is a hypertension, and patient also started to have this feeling of dizziness and lightheadedness during exercise, right? Blood pressure little fall down. Patient's ECG showing SVT. So the question is always like, what are you going to choose? And all of these things can give you a SVT, like dehydration can do it, hypertension can do it, ISD can do it. But if you think about this patient as a whole, what do you think the most important thing that you want to rule out? Yes, very good. Ischemic heart disease is the most important thing, because if it was a case of like, let's say 20-year-old was having this feeling dizziness while exercise and ECG showed SVT, I would think about possibility of dehydration. But when a 60-year-old on multiple risk factors, especially say a smoker who is hypertensive, having this symptom, I would rather think it as a ischemic heart disease as my first diagnosis. Even though chest pain is not here, still that would be the first thing that I would rule out, because sometimes the underlying cause of supraventricular tachycardia can be ischemic heart disease, right? If you have remembered, we just had a discussion about SVT, and SVT, one of the cause that you rule out is ischemic heart disease. So it all depends as a whole about the medical history that you get from this stem, the age, sex, risk factors, everything matters when you choose a particular option, okay? Very complicated. Next, a ECG with bradycardia and prolonged QT syndrome. Patient came with chest pain for 15 minutes and then relieved by rest. Troponin normal, pulse normal, regular, BP normal. What to do next? So let's say it's a 40-year-old patient. So 40-year-old patient came with a chest pain for 15 minutes, which was relieved by rest. ECG you have done showed bradycardia with prolonged QT syndrome. And now troponin is normal, others are normal. So you want to do a repeat troponin, echocardiogram, coronary angiogram, or repeat ECG. Now, remember one thing that we have discussed: when you get a patient with chest pain that lasts more than 10 minutes, we should always consider to rule out the possibility of myocardial infarction. Now, initially, ECG and troponin can be normal. You can't rule out MI unless you do a repeat ECG and a troponin. And at least you will have to do, for this kind of case, you will have to do every 4 hourly, you do a repeat ECG and a repeat troponin. And by the time it becomes 8 hours, still it is normal, then you can send the patient back home. So for this case, next means initial. Do you do a troponin first or do a ECG first? That's the question. ECG first. Okay, so repeat ECG is the first thing, followed by a troponin. Remember one thing, when they ask next, next means initial. So think about what would you do next in this patient. You would do a repeat ECG to see if there is any other ECG changes. We know that there is a bradycardia and prolonged QT, but that's not what we are looking for. We are looking for a ST changes. So repeat ECG to find out if there is any ST changes that you can give. Okay, so that's the first thing that you do, and then you do a repeat troponin. And why echocardiogram? So what echocardiogram can help in a patient with a possibility of myocardial infarction? Echo is not even our first choice in these cases. Echo is the likely time when we do a echocardiogram if it's a heart failure patient. For myocardial infarction, echo is never ever our first option. It can show a lot of things, but it's never ever we do in a patient with initial presentation of possible ischemic heart disease. If it is heart block, then again in the ECG, it would show that, right? We don't know about it. So only thing that we have got is likely to be a bradycardia with a prolonged QT. So nothing about heart block in the ECG that they have taken. And it's unlikely, like if this patient, most of the time, what happens in here that they just want to know that what you want to do in a chest pain patient. So this is more about chest pain rather than that bradycardia and prolonged QT. Okay. A woman on multiple drugs. One of them was digoxin. She presented with a central abdominal pain with tenderness. Her pulse was irregular, so it's likely to be an AF patient. And that might explain why she is on digoxin, right? Apart from CT, what is the most appropriate next investigation? Now, this is a little bit different from cardiology. You can say it's a complication of cardiology. So it's an AF patient. Any AF patient, if they come to you with a central abdominal pain, what is your main important diagnosis to rule out? Anyone? That has a name, yes. That's called acute mesenteric ischemia. So acute mesenteric ischemia, it's a complication of AF patient. Atrial fibrillation patient tends to develop clots in the left atrium. And that clot from left atrium can go to the left ventricle, then to the aorta, and through aorta, it can go to your body. And sometimes that embolism can block your superior mesenteric artery, which supplies the gut or intestine, and it can cause acute mesenteric ischemia. Acute mesenteric ischemia is common in elderly patients, and they come to you with a sudden onset of central abdominal pain. Sometimes with that, they can have tenderness, they can have a parectal bleeding as well. All right? Those patients needs an urgent treatment. The confirmatory diagnosis is CT angiogram. Along with CT angiogram, because it's an ischemic area. In ischemic area, what usually happens? Ischemic area don't get oxygen supply. So there will be a lactic acidosis over there. So if you do a serum lactate, that lactate will be high in these cases. Okay, so that's why they're asking, apart from a CT scan, what is the next investigation that you can do? That's your serum lactate. Okay, very, very complicated. If you don't have idea about it, you will never ever think about it. So that's the central abdominal pain, profuse vomiting, sometimes watery diarrhea, even sometimes you can get like a bloody diarrhea in these patients. Sign localized tenderness, patient can get tachycardia and shock later on. and the treatment is early surgery. Okay. Next question. A 23-year-old man comes for follow-up. His bilateral arm blood pressure is 140 by 60, like 140 to 160 by 100 to 110, which means that it is high. Occasional headache, rest of the physical exam and urine analysis is normal. Heart rate 75 with mild left ventricular hypertrophy. Patient is on beta blocker, thiazide, captopril. BP is still 150 by 100. What is the next appropriate step? 23-year-old young patient having hypertension and not controlled with 3 medication. Remember what we call as resistant hypertension. If you use 2 maximum dose of antihypertensive, still patient blood pressure is not controlled. That is what we call as a resistant hypertension. And if you get a resistant hypertension in a young patient, always rule out secondary causes. And one of the commonest secondary causes is renal artery stenosis. So rule out the possibility of a renal artery stenosis in such cases. Apart from that, you would also rule out other causes, like if this patient having possibility of Cushing syndrome, so do a serum cortisol. If this patient having any possibility of pheochromocytoma, so do the catecholamines or urinary VMA. If this patient having any other causes like coarctation of aorta, so all the secondary causes of hypertension you will try to rule out. Among the options, you have only got this duplex ultrasound of renal artery, which is mainly we do in patients with renal artery stenosis. And that's also one of the important cause of secondary hypertension in young patients. All right, especially if you get a young patient with a resistant hypertension, always try to rule this out. And the simple way to rule this out is to just to do a Doppler duplex ultrasound of the renal arteries. Okay. So that's that. Moving on to the next. A old man taking digoxin and hydrochlorothiazide, presents with palpitation and ECG was given. What is the cause of his problem? Now we haven't done any ECG so far, so it will be a little bit tricky for you. Now, yes, I can see one of the option in the chat box, like I think medication compliance need to be ruled out. Yes, medication compliance is always an important thing, but that's not in your option. You can always choose only from the option. Okay. But yes, medication compliance is very important to rule out in such cases because young patient may not be taking all this medication, right? So that's an important thing to rule out. Now, we have got a patient who is on digoxin and hydrochlorothiazide, presenting with palpitation. Now, this is the ECG given. You will not have any idea about it, but let me explain it so that you do understand. So this ECG, look at the V1. It's normal. Nothing else is going on here. V2, not much. If you look at V4, V5, and V6, you can see a little bit of ST depression, and it's called a down-sloping ST depression. This is called a reverse tick sign. If you get a reverse tick sign like this, especially in the V4, V5, V6, that time we think it is possibility of a digoxin toxicity. So a lot of ECG features can be there in a patient with digoxin toxicity. One of them is this reverse tick sign in the leads. So especially in the anterior and lateral lead. So this is your anterior lead, V1 to V6. And if you look at lead 1 and AVL, the lateral lead also have this down-sloping reverse tick sign. When you get something like that, that is what you will call as digoxin toxicity. And digoxin toxicity can give you this kind of symptom of palpitation. Okay. So it's all about understanding the ECG. When you do the ECG class, you will understand it much better way. So don't bother too much about it now. Next question. A patient on many medication, metoprolol, digoxin, furosemide, ECG given. Patient complains nausea, vomiting, and abdominal pain. Digoxin level is given, but it is normal. What to do? Now, this is one of the ECG that is given, and in the ECG, if you look very closely, you can see this patient has got bradycardia. Okay, it's a huge bradycardia, right? So bradycardia is one of the feature of digoxin toxicity. And if you know about what kind of bradycardia this patient has got, you will understand this is a first degree heart block also. We are not going into that at the moment. Let's just say that this patient has developed first degree heart block. And any kind of arrhythmia can be a feature of digoxin toxicity. So that includes heart block, premature ventricular complex, atrial complex. Almost any arrhythmia can be caused by digoxin toxicity. But you have given digoxin level normal. Remember one thing, even with normal digoxin level, patient can have features of digoxin toxicity. And the feature that you have got, nausea, vomiting, abdominal pain, that's a classic feature of it. So most likely this patient has got a digoxin toxicity based on the feature of ECG and also the sign and symptom. So what do you want to do next? The next option is just cease digoxin in this patient. Especially if a patient has developed heart block, the first management of heart block is to cease any medication which can reduce heart rate. In this case, digoxin can do that, metoprolol can do that. But patient has got features of digoxin toxicity. So cease digoxin toxicity in this case. Okay. I know it's a little hard for you because we haven't discussed the heart block yet or ECG yet, but we will discuss all of this in our ECG class. Okay. Next question, you have got a ECG of WPW syndrome. Heart rate, you can see 280. Systolic blood pressure is 105. Still a stable blood pressure. Now let's discuss a little bit about WPW syndrome management. So WPW syndrome, it's another kind of arrhythmic disorder. If you remember how your SA node produce electrical rhythm, which will go to the AV node, and then through the Purkinje fiber and bundle of His, it transmit throughout the ventricle. That's your heart electrical activity, right? So SA node, then AV node, then through Purkinje fibers and bundle of His, it goes to the whole heart. Now, this AV node has a property that it can block or reduce any excessive heart rhythm which arises in your atrium. So let's say that in the atrium there are some arrhythmic events going on. The AV node can reduce that heart rate, and by that way, any arrhythmia that's happening in your atrium will not transmit to the ventricle. So that's a part of your body to reduce any abnormal heart rhythm. But if something can happen which can bypass this AV node, in that way, any arrhythmia that's arising in your atrium can go directly to the ventricle. That accessory pathway is what happens in WPW syndrome. Okay, so it bypasses the AV node. Now, obviously, in those patients, they will get arrhythmia and tachycardia. So that's why heart rate is that much high. In a patient with WPW syndrome, again, it depends on if the patient is vitally stable or unstable. Unstable patient will get DC cardioversion. Stable patient, the management will depend on the medical management. So medical management, you can try almost, you can't use anything which can reduce the AV nodal function more than what it is already now, which means anything which lowered the heart rate by blocking AV node, you can't use that in this patient. And among them, you have the commonest ones like beta blocker, you can't use here. You can't use rate limiting calcium channel blocker like verapamil, diltiazem. You can't even use adenosine. You can't use digoxin. Any of these commonly used medication are contraindicated. So if you look at here, verapamil out, adenosine out. If there was a metoprolol, that was also out. Digoxin out. At this blood pressure, it is not unstable, so no need of DC cardioversion. The only medication that you can try is any antiarrhythmic medication, like amiodarone. Okay, so amiodarone, like you can control the rhythm, not the heart rate in these cases. So amiodarone is only the choice in WPW syndrome or any of the other antiarrhythmic drugs, but not anything from beta blocker, CCBs, adenosine, or digoxin. Okay. So that's one of the other management. So we are actually discussing a lot of management of palpitation chapter tonight as well. Moving on to the next one. You have got a 65-year-old patient presented with lightheadedness and palpitation. Examination was clinically normal. He is on perindropil, L-troxin. L-troxin is thyroxine, verapamil, anti-diabetic medication. ECG showing first-degree heart block. What is the next appropriate management? So you remember first-degree heart block, management is always stop medication which can reduce heart rate. So that's your first management. If patient is asymptomatic, nothing else you need to do. If patient is symptomatic, even after stopping the medication, you can give them atropine. So this patient having first-degree heart block, what you want to do? You want to increase L-troxin. If you increase thyroxine, it will cause more palpitation. And L-troxin has nothing to do with heart blocks, so forget about it. Stop verapamil, stop perindropil, add digoxin. So what do you think will be your answer here? Yeah, so verapamil will be our answer because verapamil is a rate limiting calcium channel blocker. So that can reduce heart rate more. So we will stop this one. But perindropil, digoxin, obviously we will not add digoxin in here because it can cause more damage. All right, next, a child with upper respiratory tract infection treated for infective endocarditis. Blood culture taken, treated with penicillin, but murmur still persists. What will you do next? We will discuss infective endocarditis in infectious disease class. But infective endocarditis is a cardiology thing, right? So infective endocarditis means if you have got infection of endocardium or heart valve. Many times, the initial investigation to confirm the type of the organism which has caused the infective endocarditis is blood culture. And that can definitively say which organism has caused it. Now, infective endocarditis can cause murmur. But if you have treated the patient well, then the murmur should not persist. Having a murmur means still there is a possibility of ongoing infective endocarditis. So what do you want to do next? You want to give antibiotic for another 4 weeks with blood culture weekly, echocardiogram, repeat blood culture, switch to meropenem. The only way to know that if this patient still has got infective endocarditis, is to do an echocardiogram. An echo can show definitively if there is any vegetations on the heart valve or any endocardium is having infection still now. Okay, so we'll do an echocardiogram if still murmur persists or if still there is sign of infective endocarditis, we will treat the patient accordingly. Okay, good. Next, a pregnant woman at 36 weeks of gestation presents with dyspnea and orthopnea. X-ray shows bivasal effusion and cardiomegaly. Examination shows crepitation on the base of the lung. What is the next appropriate investigation for this patient? So 36 weeks pregnant women having dyspnea, orthopnea, cardiomegaly, bivasal effusion, and bilateral crepitation. What's your diagnosis? What's your diagnosis? Heart failure, not pulmonary embolism, heart failure, right? Dyspnea, orthopnea, bivasal pleural effusion, which can be found in heart failure. Very important is cardiomegaly and bivascular crepitation. Everything is going with heart failure. Okay, so in a heart failure patient, what you want to do next? They're asking next. ECG, echo, D-dimer, CTPA. Always ECG, guys. Remember we discussed in our heart failure class, heart failure initial or next is always ECG. You would never do an echocardiogram before doing an ECG in a patient in real life situation. Okay, think about that. You have got a patient who is on pacemaker, but now having difficulty in breathing with a faint heart sound. Saturation 96, blood pressure is low, so hypotension, JVP elevated, no ECG given. What is the investigation of choice? What is the diagnosis? Difficulty breathing with faint heart sound, hypotension, raised JVP. Very good, guys. Yes, cardiac tamponade. Why? Remember the Beck's triad? Beck's triad, yes. So if a patient has got hypotension, raised JVP with a muffled heart sound or a faint heart sound, that's what we call as possibility of cardiac tamponade. For a cardiac tamponade, what is our investigation of choice? Echocardiogram, because that can give you the only diagnosis. And they're asking investigation of choice. Investigation of choice means the most appropriate or best investigation. Okay. Next, a hypertensive and a diabetic patient presented with histories of numbness. Let's say it's a 50-year-old male. So 50-year-old hypertensive diabetic, history of numbness, nausea, sweating. He developed dizziness while urinating. Pulse is irregular. ECG shows AF. What is your most likely diagnosis? Myocardial infarction, micturition syncope, vasovagal syncope. Let's say I add neurogenic syncope. What I just said is that always think the patient as a whole, not just something which is given in the option. Something in the option always can just give you little bit of drop. So something, remember that in an exam, when you see a stem, something is written as part of a clue to the diagnosis. Some are given as part of just to make you confused or a trap so that you choose something wrong. Now, Just because he developed dizziness while urinating doesn't mean that it has to be a micturition syncope. Think about a 50-year-old male who is hypertensive and diabetic, history of numbness, nausea, sweating. So nausea, sweating, having dizziness, ECG showing AF, and one of the common cause of AF is ischemic heart disease. So for this patient, I would not think about micturition syncope as my most likely diagnosis. I would think it's a possible MI or ischemic heart disease. That's the trick in the exam. You think as a whole, not just a single point. That single point might be just there just to confuse you. Okay? Next, an old woman brought after fall who is confused. So the question will be something like that, like an elderly woman who lives alone, had a fall on the floor and stayed there for, let's say, for 12 hours. And suddenly neighbor found that patient is lying on the floor, confused. And you found that patient having bruises on both thighs and buttock, patient on a blood thinner like warfarin, troponin normal, but CK 1000. What is your next, or what is the diagnosis? Recent MI less than 1200, MI in 4 hours, rhabdomyolysis. If MI in 4 hours, still troponin should be high, right? So it's not MI because both of the cases troponin should be high. And when you have got such a history, it's likely that patient has developed rhabdomyolysis because after fall, patient was confused. And sometimes in these cases, patient can develop a complication where patient have a rapid muscle tissue breakdown. So what happens in here is that if a patient keeps on a floor, confused, unconscious for a prolonged period of time without any movement, their muscle tissue starts to break down. And when the muscle breakdown happens, there will be release of myoglobin into the circulation. And that myoglobin sometimes can occlude the structures of the kidney, and it can cause acute tubular necrosis or acute renal failure. Okay? And you will get elevated CK with a dark brown urine. That dark brown urine is not because patient having hematuria, but because myoglobin also looks a reddish color. Okay, so if you send the urine for microscopy and culture, then you will not get any RBC in the urine. You will get myoglobin. So that's what we call as rhabdomyolysis. It's a complication of prolonged inactivity of the muscle. Sometimes it can happen in a patient who had a suddenly after a disaster, let's say patient like a earthquake or maybe a huge building fall down, and patient leg was stuck under a big rock, and that leg can suffer from rhabdomyolysis because of prolonged instability or inactiveness. And then muscle tissue will break down, cause this increased myoglobin in the circulation, causing acute renal failure. Okay, the rhabdomyolysis initial complication it can cause is obviously hypovolemia, hyperkalemia, and hypocalcemia. Because of hyperkalemia, it can result in cardiac arrest or arrhythmia. Later on, it can get complicated with acute renal failure. Management initially like a vigorous amount of IV fluid that can usually treat the patient quite easily. Okay, and in rhabdomyolysis, the CK will be high, but not the troponin. Moving on, a patient on medications for hypertension, perindopril and indapamide, she feels dizzy when getting out of the bed, and it's been happening for a while. She also had some fall. Blood pressure 160 by 100, has AF. What is the next investigation? Echo, X-ray, Holter, 24-hour BP monitoring, repeat postural BP measurement. So 2 antihypertensive medication, feels dizzy when getting out of the bed. What does it mean? Likely to be a postural hypotension. And patient also had a fall, some fall. Blood pressure is high. Now we don't know is it a standing or sitting. To confirm that is it a case of postural hypotension, you need repeat measurement of postural BP. So a standing and sitting position. So what do you want to do next? Now this one is not Holter monitoring. This one is repeat for postural BP. Okay. So that's what I always say. Don't memorize the answer, understand the topic and answer carefully. Okay. +70-year-old man on ramipril 5 milligram for hypertension. So ACE inhibitor. On exam, blood pressure is still high, pulse normal, cholesterol 6.5. That's high. Normal is around 2. Rest investigation within normal limit. Which one will reduce his risk of a stroke? Low dose aspirin, clopidogrel, increase ramipril, or increase or add atorvastatin. What do you think? 70-year-old, ramipril 5 milligram is still blood pressure high. Cholesterol 6.5. Others normal. Which one will reduce his risk of a stroke? Now the problem in these cases is that you will need to find out what kind of a stroke this patient is likely to have. Excessive hypertension, if it is not controlled, it can cause hemorrhagic stroke in this patient. 150/90 in a 70-year-old, it is more risky rather than having a total cholesterol 6.5 causing ischemic stroke. All right. The main thing is that this patient, if you need to find out which one is more important to control, blood pressure or cholesterol, blood pressure, always. Okay. So not a clopidogrel in this case. Aspirin can be, but not the most important thing to reduce his risk of stroke, because he is not having AF or something like that. Between these two, both of them is important, but for him, because his blood pressure is actually not controlled, increasing ramipril to 10 milligram and controlling the blood pressure will be the first thing. Because with this kind of blood pressure, he will end up having a hemorrhagic stroke even before getting ischemic stroke. Okay. Next, a 57-year-old man complains of anorexia and weakness. Known case of CCF on digoxin 0.25, furosemide hydrochlorothiazide. Left complete blood count normal, sodium little bit low, potassium lower than normal. So normal potassium is between 3.5 to 5.5. ECG not given. Atrial rate 180, ventricular rate 110. What do you want to do next? So anorexia, muscle weakness in a patient with digoxin, furosemide hydrochlorothiazide, sodium, potassium both low, and you can say the patient might have a little bit of tachycardia also. You want to increase furosemide, okay? Or you want to, let's say you want to increase hydrochlorothiazide, stop digoxin, add potassium, defibrillation, cardioversion. Now tell me, what's your most likely cause? I would say that, let's say, cis hydrochlorothiazide is also your option. What would you do? All right, now let's say atrial rate 180, ventricular rate 110. We don't need to do defibrillation or cardioversion for that. Okay. Now we have option of increasing furosemide. This patient most likely, like not most likely, already having hypokalemia and hyponatremia. Do we need to increase furosemide? No, because if you increase furosemide, potassium will become less, right? So it will cause more hypokalemia. So that's also cut out. Now you have got options of either stopping hydrochlorothiazide. If you stop hydrochlorothiazide, that can help with your sodium and potassium, because hydrochlorothiazide can cause hyponatremia and hypokalemia. Now, if a patient having hypokalemia, it can cause digoxin toxicity, right? And digoxin toxicity itself can actually present with anorexia and weakness. So you have another option of stopping the digoxin and add some potassium. So your option is between these two. Both of them is best choice, but which one is better? That's the main thing. Among potassium and sodium, potassium is most important. And anorexia goes most with digoxin toxicity. Okay, so it's a better idea to stop digoxin and add potassium. All right, so that's actually the confusing part in the exam. Sometimes two options can be equally fine to choose, but you will need to just weigh which one is the best in this case. All right. Okay, I think we will stop it here tonight. That should be more than enough for tonight. I hope that you guys learned a lot about how questions can come in the exam. And you might have also learned that how in the exam, it's not just understanding the topic, it's also about understanding the stem. Like someone can know everything about heart failure, still they can end up getting a wrong answer from a heart failure question, because the question is not that much easy in the exam. Some question might be that like a really easy, some question can be quite tricky, just like that we have done today. Especially the cardiology questions are quite tricky in the exam. As you could see that if I would not give you enough explanation, these questions would be quite abnormal, and you could discuss a lot about the options. Okay, so it's all about in the exam understanding the theory and implementing those theory to understand the question. Find out what's the clue and what's the trap. Not thinking that something given in the question means that I will just choose that one, like that micturition syncope question. Because it's written micturition in the stem, I would just choose micturition syncope. That is the just a beginner choice. When you do a lot of preparation, you will end up understanding that something which is very much evident on a question, it is very unusual to be the answer of that question. Because that's most likely just a part to confuse you. And this kind of understanding usually happens after solving a lot of questions. And you will get to learn a lot of these questions in our course anyway. We have thousands of questions in your portal already, which is solved, and you can just go through that. If you are confused, you can discuss it in our portal. You can discuss it in our question solving groups. So a lot of ways to learn from others and from us. And you could see the November candidates like how much candidates passed from the course. Okay, so it was like a 99% passing rate. Everyone who attempted passed except just one candidate, which I know just got 249. That's like a very unfortunate. But almost everyone else who was first time attempt, everyone passed. So that shows that how much we are giving to our students. And if you can follow everything that we are showing in the class and the course, if you actually give time to prepare, there is no way you will fail this exam. It is tricky and it's a lot to prepare, but with appropriate guideline, it is quite doable. Okay, now you might be knowing that this is your last class of free 2-week session with me. And tomorrow there will be a class with this recent question solvation. So you might have already gotten quite a good idea about how the classes happen, how we take our classes, how the course is going to help you. If you're still interested to join the classes, feel free to message me or just send us an email so that we can start the process. Okay. Any question about the course or anything that you want to know? All good then. So that should be the end of tonight's session. Please come and have the class with Dr. Rabia tomorrow also with the same Zoom ID and password. And that will be our end of free 2-week session. And after that, we will start the course classes in the full rhythm. You might have already got the course routine for the next 3 weeks in your Facebook group. Okay, so we will just follow that, and hopefully you will also get a orientation session with us that how MCQ works, and we will just get to know each other. We will show you how the portal works so that you don't get confused and you can get most out of it. Okay. And about the class upload, Dr. Devi, we take at least 24 hours to upload the class because this is a huge recording. It takes some time to get uploaded in our portal. So it will take at least 24 hours. No, the Zoom link will be changed after this 2 weeks free session. You will get the Zoom class ID in your course group. Okay. All right then. Have a good night. We will see you again tomorrow. Take care.